Hi, everyone, and welcome to the Parkinson's Foundation Expert Briefing. This is the third in our six-part series for the year, and I'm Dr. James Beck, Chief Scientific Officer of the Parkinson's Foundation, and it's a pleasure to have you with us today. Today's briefing, we're going to be covering issues around three prevalent nighttime interruptions: Restless Legs Syndrome, REM Behavior Sleep Disorder, also called RBD, and insomnia. We all know that these are things that can affect individuals with PD and their care partners. So this session will provide an in-depth look at the causes, the symptoms, and practical management strategies for these sleep disorders. But before we get started, what we always like to do is get a sense of who's joining us today. So on your screen should just popped up a little poll giving us opportunity to tell us what's your connection. Are you a person with PD? Are you a care partner, a spouse? Do you have a family member, loved one with Parkinson's? Or maybe you're a health professional who's also interested to hear some of these discussion points we'll have today. So feel free to click through that, and in just a moment we'll get a chance to see who's here. We've got a growing audience as people are coming in, and not surprisingly, we see a lot of people who are living with Parkinson's as well as their care partners maybe joining us as well, and then a good number of physicians, healthcare professionals. So welcome everyone as to our expert briefing today. So before we begin our expert briefing, I'd like to take a moment to introduce the Parkinson's Foundation. So as a nonprofit organization, we're dedicated to improving the lives of those living with Parkinson's by enhancing care and driving research forward. Our efforts are deeply rooted in a collaboration with the Parkinson's community, ensuring that everything we do aligns with the needs and priorities of those living with Parkinson's. So today's program is just another example of how we're working with you to meet these goals. And one of the things we do at the foundation is invest in research. We've invested over $450 million in research and care to improve the diagnosis and treatment and scientific breakthroughs for Parkinson's disease. You might be able to see that in the next slide. One of our key initiatives, PD Generation, offers free genetic testing and counseling to people with Parkinson's disease. By participating, you can learn about your genetic connection to Parkinson's and contribute to research that drives treatments, hopefully new treatments, and one day a cure. We encourage everyone to share this opportunity, and if you haven't taken part of it, I think you should. And together, we can make a difference, because at the foundation, we invest in both research and care for those living with Parkinson's disease. And then as a friendly reminder, today's expert briefings, as all of them are recorded, and that will be available online shortly. So there's no need to check back to our website to see if it's posted. If you've already registered, we'll email you a link to the recordings, so as well as some other resources related to today's topic. So you can have that at your reference to go back and watch at your leisure, and share that with other people who haven't had a chance to partake in this expert briefing as part of the process. Today's expert briefing and our PD Health at Home series is presented to you by the Light of Day Foundation, whose generosity has made this programming possible. So I'd like to give a shout out and thank you to the Light of Day Foundation for their support. And today we're honored to be joined by our expert presenter. Dr. Roneil Malkani is an associate professor of neurology at Northwestern University and a neurologist at the Jesse Brown VA Medical Center in Chicago. He specializes in sleep and movement disorders with a focus on sleep and circadian rhythms in Parkinson's disease, dementia, REM Sleep Behavior Disorder, as well as Restless Legs Syndrome. Dr. Malkani serves on the board of the Illinois Sleep Society and has contributed to national committees for the American Academy of Neurology and the American Academy of Sleep Medicine. Dr. Malkani, thank you for joining us today.
Thank you for the introduction and the invitation to present. It is an absolute pleasure to be a presenter here for the Parkinson Foundation Expert Briefings. And yeah, it's a way for me to be able to reach people who want to know more about sleep in Parkinson's disease and how we can make it better and how we can improve people's lives with that. I will share my slides in a sec. Go. So we're going to focus today on nighttime interruptions in Parkinson's disease. And there are many different sleep problems that can happen, and I'll briefly touch on that, but we're going to talk a little bit more some of these nighttime issues that occur. As far as disclosures go, I have none relevant specifically to this presentation. As mentioned earlier, I Also work for the Department of Veteran Affairs, and I do not speak on behalf of the federal government. So these are the learning objectives that were presented with the flyer and the talk. So we're going to be focusing on restless leg syndrome, REM sleep behavior disorder, and insomnia, and how this impacts our quality of life, and learning what these disorders are, how to manage them, and when to get them out. So let's start first with why sleep? What's important about this anyway? So one of the founders of the field of sleep medicine said this about sleep. If sleep does not serve an absolutely vital function, then it is the biggest mistake the evolutionary process has ever made. We're supposed to be spending about a third of our day sleeping. It's got to be doing something really important. And in fact, there's been lots of research showing that sleep is not just for the brain. Yes, it is very important for the brain, but it's important for the whole body. It's important for our heart health, gut health, metabolism, immune function, all across the board. And so it is very, very important, to value sleep so that we can, not just function better from a cognitive and movement standpoint, but for our whole body. So I often start these talks with an example of a type of case that I would see in my sleep in Parkinson's clinic, because this helps set the tone for some of the things that we deal with. So this is an amalgam of cases I've seen, not just like a single patient, but this is a very typical case I might see. So 63-year-old man with Parkinson's reports sleepiness during the day, but also difficulty sleeping at night, taking several naps unintentionally. The naps can be an hour or two, but feeling tired. But there's a lot of problems with the sleep at night that contribute to this too. So he reports difficulty staying asleep, can't sleep for more than 2, 3 hours because maybe it's going to the bathroom in the middle of the night, difficulty turning in bed, maybe there's joint pains. And this highlights not just that there's disruptions in sleep at night, and it can vary in terms of causes, but there's nighttime urination, there's maybe some more motor slowness or stiffness from the Parkinson's disease that affects the comfort in the bed. There's also joint pains, associated with aging and arthritis. So there's a lot of different factors that can contribute to this, and not just impact how we sleep at night, but our functioning during the day. Sleep issues are extremely common in people with Parkinson's disease. And if we look at across any sleep issue, how common is it? Can be up to 98% will report some issue of sleep disturbance at some point. And so very, very common, but everyone's a little different on what particular sleep problem they have. And there are many different types. There can be more problems with difficulty with falling or staying asleep. Sleep fragmentation in particular is one of the most common things that we hear about. There's circadian rhythm or internal clock issues that can happen, daytime sleepiness, sleep apnea, REM sleep behavior disorder, which is where people will act out their dreams, maybe have very vivid dreams, and restless leg syndrome. So we'll be touching on a few of these things, not all of them, but all of these things taken together or in whatever combination can really impact the quality of life, because it goes to how rested you are, how you feel during the day, the cognitive, the motor function, just quality of life and feeling well. And many of these things can also impact the caregivers, not just with how one functions during the day, but also the disruptions at night. There are many reasons why this can happen in Parkinson's disease. So, the schematic here on the left is just showing some of the anatomy of the brain that's involved in the sleep and wake cycle. In particular, this is in wakefulness. But there's a lot of different parts of the brain that are involved in regulating sleep and wake. And some of these occur even in the midbrain, which is also areas that are affected, the main area that's affected in Parkinson's disease, but as well as others that can be affected in the brainstem as well. And issues in these areas can affect our ability to sleep and stay awake. There can also be changes in our internal clock that there's been a number of studies showing this now, but there's other things too. Depression, for example, is more common in people with Parkinson's disease. It's also more common with aging. There's many medications that are involved, and other factors I mentioned, like arthritis before, that can disrupt our sleep. So there's, when we try to piece this out, it actually can be this sort of complicated web of circadian rhythms and sleep, which, we can talk about them separately, but they often go hand in hand. And then there's the neurodegeneration that occurs in Parkinson's disease and how these two interact with each other. And this is most likely a two-way street. It's not just that the changes in the brain lead to these problems, but there's some new data showing that these sleep problems can affect the neurodegenerative process as well. But these two together can cause sleepiness during the day and insomnia. One can also induce the other, and there's many different contributors to these, including sleep apnea, medications, underlying mood disorder, going to the bathroom at night, restless legs, and others. So, yeah, it is this complicated web where one thing can feed into the other. So let's talk more about these nighttime interruptions that occur. So, yeah, we're going to talk about these three today: restless leg syndrome, REM sleep behavior disorder, and sleep fragmentation and other insomnia. And so I'm going to go one by one, covering everything about restless legs and REM sleep behavior disorder, and then sleep fragmentation, insomnia, and I'll delve into what it is and management strategies for each. So let's start with restless leg syndrome. Start with a couple of cartoons about a restless leg syndrome. I yeah, and restless leg syndrome has gotten kind of an interesting reputation. Some are not sure that this is actually a real thing because of the name restless leg syndrome. It kind of sounds, yeah, almost made up, but it is an actual condition, and we understand the physiology behind it. And so this has also been known as Willis-Ekbom disease, because that's actually what it used to be called before it got this name. But I will continue to call it as restless leg syndrome or RLS because that is how most people know it. So, what is restless leg syndrome? The diagnosis is actually made purely based on the story. And we think about it as with this acronym URGE. There's this urge to move the legs. There can be this uncomfortable sensation. Everybody's a little bit different. It can be some tingling, burning, achy, creepy crawly, um, just uncomfortable. And people can have a hard time describing what that is. Regardless of what kind of sensation, there has to be this urge to move the legs. It's like kind of need to move. And resting makes it worse. And so we see this especially at night when getting in the bed, but maybe even sitting on the couch watching TV or on a long car ride or on the plane. Yeah, when you're sitting in for a long period of time where you can't really move, it can come out in some people. Getting up and going or movement makes it better. So as you can get up and walk around, it gets better, at least for the time that you're moving. And that can last for a while, but for some, it only lasts as long as they're moving. And that it's evening predominant. And so happens mainly at night when getting into bed, or maybe in the evening when winding down. If this happens all day long, there's no variation, and there never has been a variation in day versus night, then it would not be typical for restless leg syndrome. Now, there are many causes for this. The most common ones that we see, other than it just happens in and of itself, are iron deficiency and medications. Typically, antidepressants, not all antidepressants, but some of them do this. And, but some people just have this regardless of these causes. Now, there's been this question about Parkinson's disease and restless legs syndrome. Is there a link between the two? And the reason is because the medications that we have used for Parkinson's disease also work in restless leg syndrome. They're both dopamine acting medications. And so this led to this question of, are people more likely, is restless legs tied to Parkinson's disease, or do people with restless legs, will they develop Parkinson's disease down the road? And so the issue with this is that, yeah, the underlying causes are very, very different. People with Parkinson's disease have a loss of the dopamine containing cells in their midbrain. But in restless leg syndrome, actually, what we're seeing is that there's more dopamine production. And it's just that the signaling, in other areas of the brain are affected. And so, yeah, and the medications are used to boost that signaling rather than replace the effect of the dopamine that has been lost. So there is a potential link, though. So in people with restless leg syndrome, when we give these dopamine medications, after a while, the signaling actually can get a little bit worse and can cause what we call augmentation of the restless leg syndrome. And so this is where the symptoms actually get worse and start earlier. So it could be that, people with Parkinson's disease, may be more like, may have restless leg syndrome, but we may be seeing more of this effect from the dopamine medications. Unfortunately, we can't just stop the dopamine medications because you need this for the movement aspects of the Parkinson's. And so we need to find new ways to address that. And so that's one thing that we do in the clinic as well. When it comes to treating the restless legs, there are lots of different treatments that we have available to us. So, the first thing we always do in the clinic is evaluate for the iron levels. It doesn't have to be low, low just to consider it low to treat it because people with restless leg syndrome need a little bit more iron in their blood to get enough of in their brain. And so, my first line is always addressing iron deficiency with either oral iron or intravenous iron. The next line of treatment are alpha 2 delta ligands, and these are things like gabapentin and similar medications. And these are the first line, and they do work pretty well for most people. But some people can have a hard time tolerating them, and so or they don't work, and then we have to try other things. The dopamine medications, these are ones that have typically been used in Parkinson's disease, and for a long time have been used in restless leg syndrome as well. These can be very helpful. Now, in people who don't have Parkinson's disease, we actually tend to avoid these now because of some of the complications I mentioned, the issue with symptoms getting worse over time. But we can still use these in a pinch and if we really need to. And in people with Parkinson's disease, some of these medications are already being used. And so we can't just come off of them. And sometimes we have to adjust the timing and the dosing and which type of medication, et cetera, to try and help control the restless legs. Now, there are some other ones that we use as well in severe cases. There are some long-acting opioids that can be helpful, and a few other medications. In addition, there's a new treatment that is now available. It is recommended in the new guidelines for restless leg syndrome, which came out last fall, which is a non-medication strategy called tonic motor activation, or TOMAC. And this is a nerve stimulator that is worn on the leg below the knee, and it provides a stimulation for 30 minutes and can be used multiple times a day. Typically, 30 minutes when you get into bed, and then it turns itself off. And then if you wake up in the night and you need some more, you can turn it back on again. This is something that requires calibration, so it's a process involved. You can't just get it and start wearing it. But this is FDA approved for moderate to severe and is available in many states, not all states yet. But they're making their rounds to get the approvals in each state. There's a process involved, which is why it's taken some time. But yeah, this is a treatment that people are using already for this. I'm going to move on to REM sleep behavior disorder now. And again, if there's questions that come up about restless leg syndrome, we'll address that at the end. If there's questions about other sleep issues that I don't cover, those can also be addressed at the end. So let's talk about RBD, or REM sleep behavior disorder. I'll provide another story here because some people with Parkinson's disease have this, some people don't. So just to set the stage so everyone knows what I'm talking about here. So this is, in this case, we've got a 69-year-old woman with Parkinson's who it reports acting out dreams in her sleep. The events that are reported are things like pounding on the bed, screaming, talking in harsh or profane language. And you know what? In doing some of these things, she's fallen out of bed a couple of times. She's hit her head, maybe and broken her toe once. So there have been some injuries. There's no bed partner, but that would be considered if there was a bed partner, potential injuries to them. These occur more in the second half of the night. And that's actually when the REM sleep tends to occur more. And when asked about what kind of dreams she's having with this, she's like, you know what? There's a lot of variable dreams, sometimes about packing up and leaving, or school, or someone she used to date, but there's nothing violent. Though many times when we hear about these dreams, they tend to be more about being attacked or chased by an attacker or an animal or a person, or they can be about sports, and something exciting. So she didn't have those, but she does recall having a lot of dreams. So, this is typical of something called REM sleep behavior disorder. REM sleep is the stage of sleep that is most associated with dreaming. So when you think about I'm having a lot of dreams or vivid dreams, that's typically REM sleep. What happens is that when we're in REM sleep, there's a switch in our brain that paralyzes our body for the most part. And it's a protective mechanism so that we're dreaming, but we're not actually acting out our dreams. Our bodies are staying mostly still, maybe a little twitches here and there, but nothing more than that. But in people with this condition, that switch fails. And so that our bodies are not consistently paralyzed. So it allows our body to actually manifest the things that we're dreaming about while we're actually dreaming about them. And this is not something that is like constantly off. This can vary in terms of frequency, can come and go. But so these dreams get acted out, and that can raise risk of injury to oneself, to the bed partner. It could be falling out of bed, punching the headboard. And these things can be aggressive and fighting. They can be mild and just some mild movements, but they can be fighting and punching and screaming because many of the dreams can happen like that. And these things can occur once in a while. They can occur many times a night or anywhere in between, and they can ebb and flow. They can get worse and they can get better over time and then worse again and so on. If we look at how frequent this happens in Parkinson's disease, almost half of people with Parkinson's have had reported symptoms of this condition. So there have been lots and lots of studies. Putting them all together, we're at about 46%. So, and this is associated with higher age and worse motor problems in Parkinson's, more memory issues, more sleep problems. And so this it goes along with some of the other markers of disease severity. Now, why does this happen? It's, as I said, it's pretty common in Parkinson's disease, and it can actually occur even before the first symptoms of Parkinson's by, on average, 8 years. So, yeah, this is something that is considered part of that process. And for some people, it starts before the Parkinson's disease. For some people, it starts on or after the diagnosis of Parkinson's. But there are some other causes too. Certain antidepressants can induce this, sleep apnea can do so. There's some mimics for this that are completely unrelated to Parkinson's. And there's some other disorders as well that do that. So in terms of how we make the diagnosis, that diagnosis typically requires doing a sleep study where we can look for the signature of that and also look for other causes. But the first thing I always do, even before we even get to that, is talk about safety, because the biggest concern here is risk of injury. And so I always recommend moving away, or padding bedside furniture. You can get these corner cushions to stick on the nightstand, so you're protecting the corner so that if one falls out of the bed, they don't hit a sharp corner on the nightstand. Maybe padding the headboard or wall, removing things that could be injurious, including weapons. Some people do have bedside firearms or other weapons, and that can be pretty dangerous if one in their sleep grabs something and starts using it. So removing that can be very important as well. Because of the risk of falls, using a bed rail or putting some soft carpet or a mat on or cushioning on the floor, or even lowering the mattress and box spring. So instead of having it on a frame, putting it down so that there's less distance to fall. For those who have bed partners, having a pillow barrier or sleeping in separate beds can be helpful to reduce the risk of injury to the bed partner. So treatment for this, as I mentioned, is the safety first. Okay. And, although I've got to repeat it here because I really cannot stress that enough. Now, if there's one who if there's concern for medications that are worsening the condition, then, there has to be discussion of whether or not that can be reduced. That is not, feasible in all patients. If there is underlying sleep apnea, treating that can be helpful. Even if sleep apnea is not the underlying cause, treating the sleep apnea can help reduce some of the symptoms or some of these events. And we often use medications. Most of these are prescription medications, but our first line actually tends to be melatonin. And I always start at 3 milligrams, and we can bump it up depending on how frequent these events are to 12 milligrams as well. There are other treatments that we use when these fail or can't be used for other reasons. But these are the ones that are helpful to help suppress the acting out of the dreams. Now let's move on to insomnia, where I'm actually going to spend a lot more time on here. So this is very, very common. As I mentioned, most people with Parkinson's have some degree of nocturnal disturbance. And about a third have more moderate to severe nighttime sleep problem. And this, is not just with falling asleep, can also be staying asleep, can be both. And this can lead to more problems with functioning during the day in terms of sleepiness and fatigue. There are many reasons why sleep can be fragmented. Could be the Parkinson symptoms in the middle of the night, more tremors, more slowness, difficulty turning in bed, getting comfortable, difficulty getting into the bathroom because of the slowness. Some people also have actually dyskinesias, more extra movements that are occurring more at night. Going to the bathroom at night, nighttime urination or nocturia, very common. And it's because not just of the disruptions of the sleep that are happening, but also can be changes in the control for the bladder at night can be, and even during the day. In men can be prostate issues. Women, there are other factors that can affect the bladder control. So a lot of reasons why this can happen. Mood issues also, depression, anxiety is more common in people with Parkinson's, so these can be a factor. Medications that we use for Parkinson's disease or otherwise can affect our sleep. Sleep apnea, many people with sleep apnea may have difficulty with sleepiness during the day, but it can cause disruptions in sleep at night. So treating that can help improve the sleep continuity as well. Restless leg syndrome we've talked about, circadian rhythm problems can contribute to this as well. And these are all different problems that factor here, but you know what? Some people can just have insomnia and it's not due to these things. And that's actually common with aging as well. So it can be its own problem as well. When it comes to the nighttime Parkinson's symptoms, this can be, as I mentioned, nocturnal off time where the medications have worn off and now there's more stiffness and difficulty turning in bed, or it can be more on, so there's more dyskinesias. Now, for this, medication adjustment can help. Maybe it's adjusting how the nighttime dosing, long acting dosing, doing something in the middle of the night. There's a lot of things that we can do to address the Parkinson's medications effects here. So, to help with this. So usually this is something that is easier to address. The nighttime urination, it's very, very common in Parkinson's, and there are medications we do for that. There are certain medications specifically for the bladder. For some people, they get botulinum toxin injections to help improve the bladder control and reduce this. But first line, watching the fluids at night. And if one is taking water pills, then to see if that can be adjusted or in terms of the timing or the dosing, if we think that that's a factor there as well. Other things I didn't mention are things like caffeine, alcohol intake. Those things can also affect not just the sleep, but also urine production at night. Uh, One thing that I've not covered here in this talk generally is sleep apnea, but sleep apnea can also increase urine production at night and is another factor here as well. So if one has sleep apnea, treating that can help reduce the bathroom trips in the night. So let's talk about insomnia in a little bit more general terms here. Okay. When we think about insomnia, we think about it as a model of three P's. There's the predisposing factor, which is, what, maybe being a light sleeper, family history of insomnia, maybe history of depression or anxiety or other things that raise our risk of developing insomnia, but no insomnia at that point. The second P hits. There's the precipitating factor here. Now we've hit a threshold for developing insomnia. And, when one has this, there's a stressor. Maybe it's one big thing, a change in job, change in, maybe somebody in the family got ill or oneself got ill or, relationship status or something, any sort of stressor. Sometimes it's not one thing, sometimes it's a lot of little things all coming together. But the stress has induced the insomnia. And, usually people will say, okay, I know why I'm not sleeping well. I got all the stress. But over time, that gets better and that gets less and less. But what happens is the third P takes over. These are the perpetuating factors. These are the conditioned responses and maladaptive behaviors that keep the problem going. And so what happens here is that people will be in the bed, they'll try and sleep. I need to sleep. Why can't I sleep? There are a lot of racing thoughts, maybe about the stress, maybe about other things, maybe about not sleeping, oftentimes about not sleeping, but frustrations. I need to sleep. Come on, I need to sleep. And then the more you chase after sleep, the faster it can run away. And so, yeah, what's happened here is that there's this maladaptive attitude and behavior that keeps the sleep from coming back. And, these are those perpetuating factors. So another thing I want to touch on about this is that mood aspect. So depression and anxiety have definite impacts on sleep. People who have a depressed mood also tend to have less sleep, more insomnia severity, more. There's also we see fatigue and sometimes sleepiness during the day in the setting of depression. But when we think about this, this is, these are two aspects. There's the mood and there's insomnia, but this is not just one way where the mood causes insomnia problems. It's also the other way. This is bi-directional. So insomnia, difficulty sleeping, worsens the mood and feeds into this problem. And so we need to take this and unravel this. So, yeah, and so oftentimes we'll end up addressing both the insomnia and the mood at the same time. So how do we make the diagnosis of insomnia? So, um, first thing is we got to take careful history here. Okay, we need to find out the pattern. What are the problems? Is it falling asleep, staying asleep? When did this happen? What are the perpetuating factors in that one person that seems to keep it going? What's been tried before, whether it is medication treatments, non-medication treatments, what are the strategies that have been employed? What are the things that one is doing before sleep? How much physical activity, how much light exposure? Um, you're looking at the medications. We're looking at also what's happening in the sleep environment. Is it a cool, dark room? Is there noises? Pets in the bed actually can be disruptive to sleep in some people. Uh, what about the sleep schedule? Bedtime, wake time, middle of the night awakenings. Is this vary from day to day, from weekdays to weekends, or work days and non-working days? So we're looking at where it is on average, but also a lot of the variability there. What symptoms are there at night from the Parkinson's or pain or restless legs and acting out dreams, all this stuff. And so when we get all the careful information here, then we also can use surveys to help quantify maybe issues with sleepiness or sleep quality. And then we do something called sleep logs or sleep diaries. And so this is an example of a sleep diary. This is, well, where we have somebody mark, when they, the day of the week, if they're working or not. When they get into bed, that's that down arrow. When they get up out of bed, that's the up arrow. C is caffeine. This person's having coffee every morning. And then looking at the sleep timing. So the shaded areas relative to the time listed above are when this person's sleeping. And you can see that, the how long it takes to fall asleep can be less than an hour, could be an hour and a half, can be more or less. A lot of variability there. There's usually two, maybe three awakenings, varying how much that is lasting for, when that happens. So there's a lot of variability here, but the sleep is interrupted. and occurring in multiple bouts through the night because of these interruptions. And so this is an example. There's a lot more, can be a lot more variability, maybe less variability. There's, with the diary, we can also look at naps during the day and see how that might be impacting. And we can also tag on, more specific things here, depending on the history and what we're looking for. So how do we improve then the sleep? And there are many different strategies, things that are maybe employed during the day, things that are employed at night. In terms of daytime, a lot of this happens to focus on, improving wakefulness during the day and also getting, during the day, getting exercise and light exposure, moderating or limiting alcohol intake, caffeine if used only in the morning, or earlier in the day so it doesn't interfere with sleep, limiting naps. For the nighttime, it's having bedtime routines, addressing other sleep disorders, addressing environmental issues like having proper temperature, light pollution into the room, sound interruptions, things like that. Sometimes we use behavioral strategies to address these racing thoughts and negative emotions, things like cognitive behavioral therapy. I'll detail that in a moment. There's been some newer treatments that are emerging now for brain stimulation. And so there, for example, there's electrical stimulation. There's a new device that has come out on the market for this. But there's been more research going into things like sound stimulation to improve sleep depth. And REM sleep stimulation is still, really under investigation, but it will hopefully become something that becomes a reality and something that people can use. So let me talk about cognitive behavioral therapy, because this is by many considered first line treatment for insomnia. Yes, so I mentioned there's a lot of other factors that can go into disrupting sleep in Parkinson's disease, and those need to be addressed. But if those are addressed or those are not considered to be the factor here, then we're dealing with insomnia as its own problem. Then we can talk about treatments like cognitive behavioral therapy. And this is, as I said, first line treatment because it's non-medications. It helps get to the underlying cause and unravel that underlying problem with insomnia. So what happens here is that there's this this vicious cycle of poor sleep. Negative thoughts, negative emotions that lead to negative behaviors, and these lead to worsening of the problem and more negative thoughts and so on. Cognitive behavioral therapy uses a variety of techniques that address these negative thoughts and negative behaviors to help break this vicious cycle. Okay. And so this really gets to the underlying root here. And so this has been studied in many clinical trials across various populations, younger patients, older patients, Parkinson's disease, non-Parkinson's disease, lots and lots of different studies. And that's why this is considered standard of care. And it works as well as any pill, and the effects can last longer. Sometimes we do combine it with medications. This is something that is very much like physical therapy for Parkinson's disease, where there will be a number of sessions, either every week or every other week, and where you'll get report in how things are going, and you'll get some new strategies or adjust the strategies. You'll get homework. You got to practice this, and then after 4 to 8 sessions, plus or minus a few, then things should be better. There's different techniques that are used for this, so it's individualized to each person. And some of these techniques, like doing a new exercise program, physical therapy, sometimes things get a little bit harder. You feel a little bit worse before they get better. Sometimes it takes a little bit of stress on the system to induce healing. This can be given individually, one-on-one, can be done in groups, can be done in person, can be done virtually online, like through a video meeting. There are some programs that are digital, so specific coach, you're doing this on your own with an online program. So there's many ways this can be provided. There are many books that talk about this as well. So there's a lot of different options out there to go to for books for patients to read, for people to read to help improve their sleep. So as I mentioned, there's lots of different techniques. I'll go over just a handful here. There's sleep hygiene, stimulus control, relaxation training, and sleep restriction or compression therapy. This is really like also a guideline. And there's others that there really just isn't enough time to go over. So sleep hygiene. This is, many people who've tried already to address their sleep have already tried some of these things. And this is always covered in the first visits for cognitive behavioral therapy program, because these are sort of like the bare bones, but these are not like the mainstay techniques. Okay, but I'm still going over them here. Keeping a regular schedule, regular bedtime, regular wake time. If there's a lot of variability, then the brain doesn't know how to predict, and then it doesn't, it's not conducive to having regular sleep. So having a bedtime routine, this includes having some wind down time. So have something you do every time. It's kind of like a little ritual to get ready for bed. You want to avoid caffeine in the evening, avoid alcohol or in heavy meals in your bedtime. Alcohol, yes, it can help people fall asleep, but it can be very disruptive to sleep, cause more awakenings in the middle of the night, having to pee more at night. So there is, this can actually be very disruptive. Heavy meals can cause some more reflux type symptoms, some issues, and so that can also disrupt sleep further. You want to avoid bright lights and screens close to bedtime. This has been a big issue with screens close to bedtime. So, yeah, the issue is that part of it's engaging, especially when you're doing something on the phone or the tablet, and like you want to be involved. So you start thinking about that more. But also, the lighting is very activating to the brain. On top of just being a light source, these screens are blue enriched lighting, and blue light in particular is very activating to the brain. So you want to cut off the screens at least 30 minutes before bedtime. And so instead I recommend having using reading with a lamp, an actual physical book, because that's not as much light, it's reflected off the book. I versus using the screen. But if one needs like to use the phone, tablet, listening to audiobooks, podcasts, those can provide some of that distraction without using, getting the light. If one takes naps, to try and limit it to not more than 30 minutes in the day, and keeping that on the earlier side, early afternoon rather than later in the afternoon, because that will interfere with sleep more. Exercise. Exercise, cannot stress that enough. Exercise is so good for sleep. So one of the techniques I mentioned is stimulus control. This means that if you're in the bed and you cannot, fall asleep, it's been 30 minutes or more, get out of the bed. What happens is we're in the bed, we're sleeping, we're trying to sleep, we're trying to force sleep. Why can't we sleep? And so letting the thoughts then run amok. But if we're not going to sleep anyway, why stay in the bed and torture ourselves? So get out of the bed and go do something kind of relaxing. It's still kind of rest time. Go watch a little, TV, something that you could turn off, nothing too engaging. You're reading something. When you're tired, get back into the bed and give yourself another 30 minutes to fall asleep. Although, for some people, this really works to, say, okay, you know what, I take the worry off and they're not going to sleep. But part of the thing is also to not perpetuate the negative racing thoughts. Relaxation training, there's lots of different things like this. There's progressive muscle relaxation. There's also we call autogenic training, where you're focusing on specific body parts one at a time. There's biofeedback to try and create this. You have that internal sensation of like, okay, this is what my heart rate's doing. This is what I'm thinking. How do I calm myself down? How do I adjust my breathing to affect my heart rate, my and how I feel. There's guided imagery techniques as well to help induce relaxation. The relaxation helps can reduce some of the negative thoughts and racing thoughts. But even before bed, this can help prime the system for relaxation and rest. Sleep restriction / compression therapy. This is something that's often individualized, but the whole idea behind this is that the brain has a sleep drive, and the more we're awake, the greater our need for sleep, and then we go to sleep, and that drive comes down. And so, what we're doing here by limiting how much time we're in bed, we might actually get a little less sleep, but that revs up that brain's drive for sleep, because maybe instead of getting 6 hours of sleep, now you're getting 5.5, and your brain is, the brain's maybe getting, still not sleeping well, but functioning on 6 hours, but now 5.5. Ooh, that's really not enough. And so the brain's drive for sleep starts to get a kickstart. It's to start working well again. And then when one's sleeping most of this time, so you get a little less sleep at first, but eventually you start sleeping more and more of that time in bed. And once that happens, then we gradually lengthen the time in bed. And then as long as one is sleeping most of that time. This, it's work, but this really works well. Now, when these techniques, let's say these are not feasible or they don't work, or we really want to try medications, then there are a lot of medications that have been used, both approved medications, off-label medications. These are the ones that are often used. And it's a big soup of stuff, but you try to split this off into thinking about those that promote sleep, those that inhibit wakefulness, because it's a balance between sleep and wake, and then those that things like melatonin type medications and so on. The ones that are approved for use are things like zolpidem, ecopiclone, zaloplan, doxepin, and the orexin antagonists. And how the choice of medication does depend a lot on you know what's going on with an individual person in terms of what type of sleep issues, other medical issues, mental health issues, what other medications they're on. So there's this is something that's very individualized here. Now, those are the general medications. There have been some medication studies specifically in Parkinson's disease, and I've highlighted that here. So, for those that, from the insomnia angle, the ones that really pop out, melatonin can improve sleep quality a little bit. Sodium oxybate has been shown to be helpful, but this is not typically used in Parkinson's disease. Bright light therapy, cognitive behavioral therapy definitely improves insomnia symptoms. Um, yeah, well, bright light with cognitive behavioral therapy, some data on bright light therapy improving sleepiness during the day and also potentially improving insomnia. Low dose doxepin has been studied. This is usually one of my go-to medications when we do this. This can be helpful. Ecopiclone, which is another sleep promoting medication, can. The others have been studied more so for sleepiness during the day, but safinamide, one study showed improvement in sleep quality as well. So there have been some studies in Parkinson's disease as well. So some things that we know may be a bit safer in people with Parkinson's. So I want to take a moment about that bright light, because this also is another non-medication strategy that we can talk about that can be helpful. Now, there was a study showing that bright light therapy can improve daytime sleepiness in Parkinson's disease. Recently, there was a study that was just completed. It's not been published yet on bright light therapy for insomnia in Parkinson's disease. But yeah, and so there's no one right protocol for this. It really depends on the individual. If their clock is more delayed versus, where they're more of a night owl versus a morning person, or a morning lark kind of a person, depending on the scenario is how we would time it. But there are different options that we use for bright lights. There's small devices that can sit, on the table by the computer. There are wearable ones that are often used. But I'm a big promoter of natural light. Sunlight is better than any light box. And you don't have to be directly it doesn't have to be a very bright day. Even a cloudy day, it's very bright. So getting some natural light is actually very good for the brain. And for those who are in nursing homes, there have been some studies even using light tables so that people are, maybe looking down a little bit more, they're still able to get that light, and that can help improve sleep. Ultimately, though, when we're dealing with insomnia and sleep disruption, and even daytime sleepiness, I always think about doing what we call a multimodal approach, meaning lots of different things all at once. Bright light, exercise and physical activity, social activity, going out for a walk and talking, it helps stimulate the brain, even things like yoga and which train the brain in different ways. And this can be helpful for sleep. So, okay, we talked about a lot of stuff, but okay, there's some things that you can try at home, but when should I get help? And that's always a big question here. So when to see a sleep doctor? I said sleep because, this is, can be higher level things that, while some strategies may be helpful if you work with a primary doc or your neurologist, sometimes if that fails, then it's worthwhile to see the sleep doctor. So if you've tried some strategies and you're not, getting improvement in insomnia, you want to try a sleeping medication or try cognitive behavioral therapy, that's a good reason to see the sleep doctor. There's other problems: snoring, sleep apnea, restless leg syndrome, doing things in the sleep, acting out dreams. These are good reasons to see the sleep doc. Okay, but if you go to see the doc, what do you expect? What to expect? Well, you're going to get a lot of questions. Yeah, as mentioned before, we ask lots of questions. I got to get to know your pattern, what's going on with you. We talked a lot about, each individual problem today of the problems we covered, but oftentimes there's multiple things at once. There's maybe some insomnia and also restless legs or insomnia and acting out dreams, or maybe some sleep apnea. So there's often multiple things all at once. So it takes a lot of probing to try and understand what's happening. Maybe be asking patients to do sleep diaries to get a sense of the pattern. Maybe do a sleep study if we're worried about REM sleep behavior disorder or sleep apnea. There may be blood tests involved, typically if we're looking for iron levels in people with restless leg syndrome. And then we talk about all the different options, the behavioral strategies. We may have to talk about a decision, a tree where we say, okay, we're going to try this. If this doesn't work, then we'll try that, and then we'll try that, and go one thing at a time, sort of a stepwise approach. We may provide a referral for a cognitive behavioral therapy or some online resources. But again, this is and how we approach all of these problems is very individualized. So this is the Northwestern Medical Sleep Center. I show this. I also, there's also sleep at many Veterans Affairs hospitals. I didn't show that, but this is actually a little older picture. Our group is way bigger now at Northwestern, and we have clinics up in different areas in the Chicagoland area. Okay, so a few quick takeaways. Sleep problems are very common. There are many different kinds. And if you act out your dreams, please work on getting your sleep environment safe. Because that's something you can do even before you get to a specialist on this. And if you have the problems, we're here for you. Get some help. We can make things better. Okay. A couple of different places that you can go to get some more information. Project Sleep has a lot of information for people about sleep. Also, the American Academy of Sleep Medicine has a lot of information for the public to help with this. There's other places to go that are run by research cohorts that can also provide information as well. And I'll end with a proverb: a good laugh and a long sleep are the two best cures for everything.
Thank you very much, Dr. Malkani. That was an incredibly thorough presentation. I'm, you know, uh, looking at some of the questions coming in and seeing you address them as you go through. So that's really fantastic. So that's wonderful to see as part of the process. Before we get going with the questions, I just want to remind those who are listening, feel free to keep continuing to put them in the Q&A. And if you're on Facebook, put them in comment section. We'll do our best to get to them, addressing those, of course, which are on topic here. And for those we won't be able to get to because we do have a limited amount of time, my colleagues at the helpline will do their best to help. And we have a number of materials online as part of this process. So, thank you again, Dr. Malkani. Questions that come in, you mentioned the last, one of your last slides was about trying to find sleep specialists. Is it important to find one who really knows something about Parkinson's disease, or I mean, because you're maybe that rare bird, movement disorder specialist as well as a sleep disorder specialist. Um, is it enough to just work with any sleep specialist per se, or is there anything unique or challenging about Parkinson's that our listeners should be aware of and let their clinicians know if they end up seeing the sleep specialist?
Yeah, no, I think it's kind of quite variable out there in the sleep community. There are some sleep providers that are more pulmonary based, or and maybe more comfortable with things like sleep apnea. But I know many pulmonologists who do the whole gamut of sleep problems as well. So, it's like finding any other doctor. There's some that are really know, the latest and what to do, and there are some who are not as comfortable because their niche is a little smaller. But so, I mean, I think that seeing a neurologist is helpful. A neurology sleep provider may be helpful because they may be more familiar. But I know many pulmonologists who have been trained and know these things very well. And so there are many programs that also, take people from all sorts of specialties and train them in a diverse program where they may not be a neurologist, but they've seen this many times. They know what to do. So I think it's more so researching the individual provider rather than like putting people in categories here.
Yeah, understood. Some other questions which come in too. I mean, you mentioned one of the very first things you do with your, it sounds like you do with your patients is, evaluate their iron levels as part of the process, is your workup. Um, One of our listeners writes in that she had thought that iron might interfere with carbidopa levodopa, and so how do you balance, if that's accurate, how does one balance that with this? Because it seems there's a you know people with on Parkinson's have got a lot of medications that they're taking with. And so how do you, in addition to worrying about whether iron supplementation may be an issue, how do you deal with their panoply of medications they're taking and trying to figure out like what might be at the heart of their problem?
That is absolutely that's a great point here. And I'm not aware how much iron and carbidopa levodopa do interact with each other and limit absorption. You hear about that more so with other minerals. But also, one thing about iron is that tannins in coffee and tea can also reduce absorption. So
Ah,
a lot of times we're playing with the timing of it. So it may be that if there is an issue with that interaction, or if you once noticed that, then maybe timing the iron so that it is between doses and not taking with the dose. And so, although a lot of times people take it with food, iron does not have to be taken with food, as long as it's not causing an upset stomach. So the timing of it can be adjusted.
and then it's interesting too. Again, one of the issues you raise is for people who have insomnia or other issues with the sleep interruptions, the fragmentation, forgetting up to use the restroom. Again, there's this fine line between cutting back on liquids, but then also, and iron can be a contributor to this too, is battling constipation. Um, ha- and then you mentioned the water pills, right, for people with hypertension, maybe taking that. I mean, it really seems like you're trying to navigate a thicket of problems, and so it's just really trying to reach a best solution. Is that accurate?
That's absolutely accurate. That every time, like every person I see in my clinic is just so different from each other. It's because there's a different set of problems, different set of medications, and everyone how they've responded and what they need. It's a lot of variability, and so everybody has to be done on an individualized level in terms of understanding what's going on and how to manage that thicket.
Yeah, it seems like you had a nice presentation about, the sleep hygiene, which seem very straightforward things someone could do at home, but it's really clear to really tackle this, you need to bring on an expert to deal with not only the medications, but also these other issues that deal with. A couple, I know we're cognizant of time, just a couple more questions if I can. This is something you hear, don't wake the sleeping person, whether they may be sleepwalking, or what about with RBD? How do you respond to care partners who may see their partner having one of these, violent dreams or they're sleepwalking? What's the suggestion that to keep them safe and as well their loved ones safe as well as themselves safe?
So that's a great point. So, yeah, different types of doing things in the sleep, I have different responses. So somebody who is a sleepwalker, while they're walking, you really don't want to try and wake them up because that can actually trigger more aggressive behaviors. I mean, that's not under their control. They're asleep still. But um, that's very different than REM sleep behavior disorder, where actually people tend to wake up pretty easily out of it. But still, like, you need to be careful because if it's very aggressive behaviors, punching and so on, you don't want to get hit. So you can do some nudging, you can do some calling out, usually people when they're acting out the dreams, they can wake up more easily out of it, and that's not so dangerous. That's not going to be like a violent response like what you see in somebody who's sleepwalking. But as I said, like, when you're seeing this as a bed partner, you want to make sure that you've got some protection, some pillows between, the person and the bed partner, just to help reduce risk of injury.
Yeah, for sure. And maybe this is a situation where you get out of bed and turn on the room light. That maybe that would be sufficient to wake them up. So you're distanced, but also provide that cue
The
that
light
it's,
itself may not be,
oh, okay.
because the eyes are closed,
Yeah,
and
yeah.
so the person may not be aware. But I mean, it can try, absolutely. But sometimes it's more that voice or a nudge that will wake them up.
Okay. All right. Dr. Malkani, thank you very much for your time. I'm afraid we've ran out of time for questions. I know that more have come in and my colleagues helped do it. As I mentioned, we do have a number of great materials online that can augment Dr. Malkani's presentation as part of that. So thank you again, everyone, for that. And thank you, Dr. Malkani, for your time today and sharing with us your expertise. I'd like to just highlight where we are in our expert briefing series. We're finished number 3, and we have, there it is. Coming up is number 6 in September. So we're going to have a little bit of a hiatus coming up for the summer months, and we'll restart again to close out our series of expert briefings in the fall with our Medications 101 as part of the process. So, look forward to that and hear what we have on tap for that. We also have our PD Health at Home. This is our ongoing series, weekly virtual programs that are fantastically produced and put together. Really, they're a wonderful series for everyone. Take a look at that QR code if you've got if you're not watching on your iPhone, you're on a computer, iPad, hold it up there for the QR code, or you can even go to our website and register, much like you did for our expert briefings here as part of that process. Um, the presentation here will come to an end, but we're here for you still. We have our helpline, parkinsons.org, helpline at parkinsons.org, or even through the call-in line, 1-800-4PD-INFO. We have a really talented group of support specialists, support staff who are very knowledgeable about Parkinson's disease. I often frequently ask them about specific questions, and they're incredibly responsive and are there for you as part of the process. Before we go, as like all Zoom meetings, it's going to go to black, but we still want you to stay engaged with us. We want your feedback to understand your thoughts of this presentation and other questions that might come up there to see what we can do to make our expert briefings better. These are something that we really rely on with every expert briefing to continually improve upon it. And it's part of our dedication to really being responsive to you, our Parkinson's community, as part of the process. So thank you very much. Take care, and we'll see you in September with our next expert briefing. Thank you.